Welcome to Histotripsy Demystified, Truths and Misconceptions Explained. During this seminar, all participants will be in a listen-only mode. Please remember that information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild, and I'm the Executive Director of the Life Raft Group, and I am thrilled to introduce our moderator for today. Dr. Elizabeth Lilley is a surgical oncologist at Brigham and Women's Hospital, specializing in soft tissue sarcomas and melanoma, with special interest in robotic and minimally invasive surgery. She is triple board certified in surgical oncology, general surgery, and palliative medicine. And Dr. Lilley, I'm going to have you take it from here.
Thank you so much, Sarah, for the introduction, and thank you for hosting this event. I'm really excited to lead a great conversation today about histotripsy, which I think has been a major interest to so many of our patients, and is also still a very new technique that we are learning a lot about. And so you'll hear today a sort of high-level overview of what histotripsy is, as well as some thoughts on what its potential role could be in the future for patients with sarcoma. There's always room for differing opinions, and I think that is actually very healthy when we're looking at new technology, because it helps us to make sure that we are doing the right thing and keeping patients safe. So to get started today, I'd like to introduce Dr. Jiping Wang, who is going to give a short presentation on histotripsy. Dr. Wang is a surgical oncologist at Brigham and Women's Hospital and an associate professor of surgery at Harvard Medical School. He specializes in treating gastric cancer, liver, and pancreatic cancers, as well as soft tissue sarcoma, and has a special interest in using minimally invasive platforms to perform cancer surgery. Dr. Wang co-leads the Mass General Brigham Histotripsy program. So with that, Dr. Wang, you can take it away.
All right, thank you for the opportunity. I would just jump to the talk. I want to share.
In the meantime, as we're getting that set up, I'm happy to introduce the rest of our panelists. So our panel will consist of Dr. Suzanne George. Dr. George is a professor of medicine at Harvard Medical School and the division chief of the Sarcoma Center at Dana-Farber Cancer Institute, where she leads a team focused on research and clinical care of patients with sarcoma and GIST. We have Dr. Alicia Gingrich. She is a surgical oncologist at the University of Nevada, Reno. Dr. Gingrich's clinical practice focuses on soft tissue sarcoma and GIST, as well as hepatobiliary tumors. The University of Nevada, Renown, was one of the early adopters of histotripsy, and they have been performing this procedure for about 2 years now for select patients with liver tumors. We have Dr. Hap-Tran Kao. He is an associate professor and vice chair of clinical operations in the Department of Surgical Oncology at UT MD Anderson Cancer Center, specializing in hepatobiliary tumors and minimally invasive surgical techniques, and his research focuses on improving quality and precision of cancer care. We have Dr. Chandrajit Raut. He is a surgical oncologist and division chief at Mass General Brigham, specializing in multidisciplinary soft tissue sarcoma care. He's nationally recognized researcher with extensive clinical trial leadership and hundreds of publications on soft tissue sarcoma genetics as well as treatment. And finally, Dr. Christina is an associate professor with tenure of surgery, associate professor of dermatology, and faculty member in the Cancer Biology PhD program at the University of Michigan in the Division of Surgical Oncology. She leads multiple clinical trials for melanoma and sarcoma at the Rogel Cancer Center and is at the forefront of developing new treatments for melanoma and sarcoma. So I'd like to thank all of our panelists for joining us today. Dr. Wang, it looks like your slides are up and you're ready to go. So with that, I'll let you take it away.
All right, thank you, technical glitch. So today, I think for the left draft, gave us the opportunity to present our view of the histotripsy. I want to say this is my personal perspective. Um, Disclosure, I'm a Histotripsy technology user. Some of the slides were provided by Edison Company, and I have no conflict of interest for this talk. And my view is based on available information to me and my limited personal experience. Therefore, that might be biased. And also, I want to reinforce the idea that this is my personal opinion, doesn't represent any other party. So what is histotripsy? Histotripsy basically is using ultrasound energy to destroy tumor tissue. This technology is nothing new. Actually, it was found a long time ago, and it has been in development for 20 years. What is different with other ultrasound technique is that it is no heat involved. It is used very small bursts of energy delivered within a few milliseconds, and that has a long interval of resting. So it uses a mechanical to kill the tumor cell. Here's a video that I identified from the internet. I want to share with the general audience.
Dr. Wang, there's no audio on our end for the video, so maybe you could explain what is happening.
Yeah, sorry. Yeah, I thought you can hear. So basically, histotripsy activates the body, the bubbles in the body, and then when the body bursts, it creates this jet. Okay, this is called cavitation. The jet force is so powerful and destroys the tissue, but usually it can preserve. There's a potential can preserve the surrounding important structures such as blood vessels, bile duct, and then leave this acellular tissue behind. And then I just want to give you an overview of the machine itself. The left side is an ultrasound machine. It's no different than any ultrasound machine we use at the clinic. And the middle is the OR table. Patient lay there, and then there is a water bath, is a box of water. And the treatment head is put into this water bath, and then the energy will deliver through that treatment head here. And this is a generator to generate the energy to deliver to the head. This is basically a big computer to have the software installed to help to regulate the energy they delivered. And on the right side is just degas machine to degas all the water we use in the water bath. And then this is just the machine itself. And then when we use it, this is all the control buttons. I don't want to go into the details, but basically they use a computer to locate the tumor, to design the treatment contour, and then to deliver the energy. And then this is once you identify the tissue and design a contour, you can deliver the energy. You can see the small bubble that very faint is magnified here. Those are the very small bubbles in your body. When it bursts, it will destroy the tumor. And here is the animal liver tissue. And then you can see the 1, 2, 3, 4, 5, 6, 7 are the computer. When we do the ultrasound, we can tell the machine where the tumor is, how the tumor look like, so that tell the computer to deliver energy to the predefined area. This is the real action when we deliver the energy to the the liver tissue, which is embedded in the gel, that it will destroy the tumor. This is a real time happening to the animal liver tissue. And then after the treatment, if we cut into the tissue we treated, you can see that tissue get liquefied. It's look like a chocolate gel. And then this is available on the internet, that this is the liver, porcelain liver treated by Histotripsy. They didn't want to show you, it is actually pretty precise. If you predefine this 2 centimeter hole, when you deliver the energy, it look like you treat a 2 centimeter the dead tissue zone. And also on the right side, you just see the shape M. That is basically want to tell you that, oh, if you design this way, design the contour the way you want, and then can deliver it. But this is the future, not now. I don't think that right now the machine cannot do the customized contour for the tumor. This is a real example that I was at the site, and then we treat this tumor. And then as we cut through, you see the lysate all become lysate. And then if you look under microscope, you see this is a treated zone, and in the center or you magnify it, you see that acellular component. Acellular means that there's no cells in the lysate. And then this is a few pictures provided by the Artisan company that showed after the treatment, you wash out the lysate, you can see some of the structures, for example, blood vessels, bile duct, or in the kidney collecting system was preserved. And also this is one of the image from the patient image treated in the Hope for Liver trial. You see the left side panel, that's the tumor. The middle one is after treatment, immediately after treatment, and then the right side is 30 days after treatment. So I just want to bring to your attention that when we look so-called data or evidence, we need to interpret it carefully. Okay, that's the one way to interpret it. But the other way to interpret, this is another version of interpretation, that when we see, okay, the left side is now, but the right side, ideally we want to design the contour can accommodate whatever the shape of the tumor is, but the current technology cannot do that. Although we look this after treatment, or the tumor cell is dead, there's no live tumor, no cell inside the lysate. However, number one, this is not real patient. This is an animal model. Number two is that I'm not sure whether this is a live animal or dead animal. It's very different. So when we see it, when we interpret it, we need to interpret it with caution. And also, same thing here. When you see, okay, all the vital structures preserved, but again, this is on animal, and I'm not sure it's dead or alive. Number two is that, energy is a double-edged sword, right? If you use the current energy, you might preserve the vital structure, but whether you kill all the tumor cell or not, we don't know, right? When you reduce energy, you might not kill all the tumor cell. When you increase the energy large enough, you can rupture all the vital structures. So don't just look at the picture, interpret, oh, this is theoretical advantage. Whether real life happened or not, there's no human evidence so far I know. Again, this is the same thing. When we treat the tumor, it become necrotic and then resolved within 30 days. But this is not necessarily happen to every patient. Some patient might have, 2 months or 3 months, still stay the same. Okay, so I don't want the general audience take it in the wrong interpretation. So just want to briefly touch on a few trials and the result, and then just tell you my interpretation. This is a Hope for Liver trial, well known, the first trial, other than the Melissa trial. This is the first trial, the international trial, which showed with 1 year follow-up, local tumor control rate is 90%, and then complete tumor coverage is 95.7%. Okay, it looks very good number, but when you look at this number, 90% local control at 1 year, you need to interpret it carefully. Why? Because if you look at the survival data, okay, the HCC 1 year is 73%, liver metastasis 48%. So meaning that 50% of tumor patient who has metastasis would die within within a year. So when they might die 3 months after. So really your 90% control rate is not at 1 year. It is from whatever you treat up to 1 or 2 years. So might be lower than that. We don't know, or might be higher. And also this is real life experience of these 230 patients who were treated in 9 centers. They report the safety data, which showed a very promising. But I want to tell you from our experience, our complication rate is much higher than what has been reported here. This is just our observation. Again, sorry, I don't have the updated data from the company, but this is back to 2020, December 2024. The data, I want to show you not a number of patients treated, but also the variety of patients, different etiologies, have colorectal cancer, liver mets, neuroendocrine tumor, pancreas cancer, cholangiocarcinoma, breast cancer, GI cancer, melanoma, lung cancer, leiomyosarcoma, ovarian cancer. Why I pointed that out, we are using the same energy level and the same machine to treat a variety of different tumor, or those tumors might have very different characteristics. The machine might not be well optimized to treat each of these type of tumor, but I don't know. I don't have evidence, but that is the question that we need as a institution or as an academic environment. This is our responsibility to carefully study before we advertise, before we recommend to our patient. And then this, like for liver, this is the histotripsy is proven for FDA approved for treating liver tumor only so far. And you can see that it has its limitation, but people have tried to different segment 1 to 8 has all been tried. And then I just wanted to give a summary. It is a new promising technology, and it's FDA approved for liver. I put all 2 green is that a fact, okay? Or is number 1 is my view. But I put an orange because I think this is need attention. Safety and efficacy need to be verified with broader application. And also long-term outcome data is needed. And then we don't jump to the conclusion, see whether it is something is super good or super bad. Don't jump to that conclusion. At the end of the day, for local therapy for liver tumor, there are so many different treatment modality. This, my view, is one of those modality, and what their efficacy need to be carefully studied. Okay, so in my view, it is belong probably to not a wildfire, but probably is candle. We need to do more study and then work with preclinical researchers such as Dr. Angeli from Michigan to optimize the machine for future optimize the clinical applicable machine. Finally, I just want to tell you that at our institution, we are on the conservative side. Although we acquired the technology back to April 2025, so far we only treat less than 20 cases. And all our cases has been performed jointly by one of the interventional radiologists and me personally. And we have a steering committee to monitor the progress of this technology. We have bi-weekly meeting. All right, thank you. That's my end of my talk.
Thank you so much. So I've already introduced our panelists, but I want to thank our panelists as well as all of the people who are joining us today, and the Life Raft group for hosting this. This webinar was created in direct response to really overwhelming interest and incredibly thoughtful questions that we as clinicians and as well as the Life Raft group has received from patients, caregivers, and advocates who are really eager to understand whether histotripsy could play a role in sarcoma. Many of you who are joining us today are living in incredibly complex situations, recurrent tumor, prior surgery, and limited remaining treatment options, or diseases that are located near vital organs, blood vessels, nerves, other things. And so our goal today is to provide clear, realistic, and compassionate answers for what histotripsy can do and what it cannot yet do, as well as where we think that the field is heading. And so for our panelists, I'm going to moderate this conversation, and certainly please feel free to chime in even if a question is not directed towards you. My first question will be for Dr. Alicia Gingrich. Dr. Gingrich, you use histotripsy for selected liver tumors, and we've just learned that that is the only FDA approved use. Could you tell us why liver was the first application, and when you're offering it, what guardrails do you use?
Absolutely. Thank you for having me today to talk about this important topic. I think this is a wonderful opportunity. So the liver was the first logical application for several reasons. It's a large, relatively accessible organ. It has a uniform density and high water content. So this provides favorable acoustic windows for the ultrasound guided targeting that Dr. Wang explained. Given the uniform density, the liver's tissue characteristics allow for predictable cavitation and precise mechanical ablation. So again, as the video demonstrated, we know exactly the tissue we're targeting and the surrounding structures. Just as importantly, liver tumors are very common, and many patients are not candidates for other liver-directed therapies, such as resection or thermal ablation, due to either compromise in their underlying liver function or the proximity of their tumor to critical structures. So there's a clear unmet need for a new technology in this space for liver tumors. Finally, the liver has excellent regenerative capacity, so this makes it a safe environment to introduce new focal therapies. In terms of guardrails at our institution, we approach histotripsy with the same oncologic discipline as any other local therapy. Our patients are discussed in a multidisciplinary tumor board with both surgical oncology and interventional radiology prior to deciding to proceed with histotripsy. We prioritize patients who are not optimal surgical candidates or who just need focal control of limited disease. Our criteria are that the lesions must be well visualized on ultrasound. We send our patients for a screening ultrasound prior to the procedure, and that same ultrasound tech is with us in the operating room on the day of the histotripsy procedure. So the lesions must be targetable and positioned safely away from vulnerable structures, namely bowel. And then, as I mentioned, once again, we just review all the cases in a multidisciplinary setting to really ensure that histotripsy is complementing but not replacing what's already established as standard of care.
Thank you so much. Our next question I'm going to pose to Dr. Tran. What aspects of histotripsy do you think are most appealing? We've had a lot of interest from patients. And where do you think that the expectations sometimes exceed the reality based on your experience using this?
Yeah, thank you for the question, and thank you very much for the invitation to take part in this webinar, which I think is really important and timely. I want to first, if you don't mind, just add a few points to Dr. Wang's presentation and piggyback off of what Dr. Gingrich has already said. It's important to understand that the technology was approved on the de novo kind of application from the FDA. What that means is that it is a relatively safe technology, right? In a space where there's not a lot of current option in terms of providing a similar type of treatment. And what that also means is that the long-term data on oncologic outcomes and efficacy is not necessarily yet proven, right? So I want to make that clear, meaning the long-term cancer outcomes related to this treatment are not yet there, but that's what we're all working towards. The other thing I want to talk about is Dr. Wang did kind of mention the disease, the pathologies that have been treated so far using this technology. And I want to clarify that those are all tumors in the liver, right? So when you see pancreas or you see breast or you see sarcoma even, these are metastases in the liver that were treated with histotripsy. Because I assume this audience has a lot of questions, and I can see that there are some questions about tumors in the retroperitoneum. Those are not yet proven, okay? So I think that's important to know. There are certainly a lot of very attractive features of this technology, right? So the fact that it's a non-invasive technology where there's no cut, there's no puncture of any kind. You're using ultrasound energy to go through the body and reach a point of critical energy to destroy a tumor mechanically. That's very, of course, attractive. The other thing where I think there is some emerging data about is that you can, in fact, treat a tumor in the liver near a critical structure, like a bile duct, like a blood vessel, and with the appropriate precautions, not damage them. And this is because it is a mechanical destruction, which was made very clear in Dr. Wang's presentation, rather than thermal destruction, right? When you use heat to destroy, you can injure bile ducts, you can injure vessels. Mechanical destruction doesn't do that because these other structures have some architectural integrity that protects them against that damage. Now, the one thing that is very often talked about, and I think this is where I really want to caution the audience about, is this abscopal effect. And I know we're going to go into it later. This concept where by treating one part of the tumor, you somehow get your body's immune system to be elevated, to be activated, to go after cancer wherever else it may be. I will say very clearly that at this point, we do not have the data to make that a reality, okay? We do not have the data to say that that is a reasonable application for the technology. So long and short of it is that it is a local therapy. It can have some benefits to treating liver tumors at this point only. That's what the FDA has approved it for. It may be of interest to other disease sites, but right now that is the only place where it currently has a role to play.
Thank you so much for that. I'm going to give my next question to Dr. Wang. So can histotripsy be used for metastatic disease such as lung nodules in addition to liver metastases, bone metastases, lymph nodes, or diaphragm involvement? And this is a question based on some of the questions that were submitted ahead of time.
Yeah, so it's a great question. So I like Dr. Chow talk about, this technology right now is only approved by FDA to treat the liver tumor. Even that, as I presented before, we don't have long-term data. Really, whether it will completely, destroy the tumor or not, what's a long-term effect, we don't know. All the reports are based on the imaging. Okay, there's no pathology, not like we do liver cancer surgery. We cut it out, we look under microscope, say, hey, we cut all the tumor out. So therefore, for anything do outside the liver, I mean, liver itself, I still be very cautious to want to see the long-term result. But if we talk about the outside liver, we need to be very, very careful right now. My personal feeling is that we should not do it unless we do under protocol to study carefully.
Thank you so much. So Dr. Gingrich, one of the questions in the chat has been about some of the complications. And I know that Dr. Wang had mentioned that we've seen, and I think all of us have seen or heard of more complications than had been initially reported. I wonder if you could tell us a little bit about some of the complications you've heard of or experienced yourself, just to give the audience an idea of what that might look like.
Yeah, absolutely. And to Dr. Trankow's point about not having the data for some of this, but there are a lot of multi-institutional collaborations happening right now to try to bring this information to the public at a larger scale for some of these experiences. So I think a really important thing to remember with histotripsy is it's very true that there are no incisions that are required. It is still a procedure and it is still destroying tissue, and any procedure comes with inherent risk. Our patients are all intubated and sedated and paralyzed to allow for the liver to stay still and not move with the motion of the diaphragm, because that affects your ultrasound targeting. So you have all the risks of general anesthesia. If the patient is not a good candidate for general anesthesia for underlying heart or lung problems, they are also not a safe candidate for histotripsy. We intubate everybody with a double lumen tube so that we can have control over the right lung in particular and raise it or lower it as we need to position the liver where we can see. It's been touched on that histotripsy can be used near critical structures fairly safely. Blood vessels are the main structure that they are safest around. The bile ducts, again, we're lacking in some long-term data. So there have been some reports of late bile duct stricture after histotripsy. There have also been bilomas reported. A biloma is when the bile duct has a defect in it and it leaks bile into the surrounding space. We have had issues as a community where if the bowel is within the histotripsy field, so the bowel is air-filled, and that can change the acoustic trajectory of the mechanical destruction. And it can cause bowel perforations. So patients have had holes placed in their large intestine, which carries a lot of bacteria, and fixing that is a surgical emergency. Two more large classes of complications that we have seen and can see are blood clots. So particularly if you're treating more than one tumor, the patient is laying on their side in a position that hinders blood return to the heart and encourages pooling of blood in the lower extremities. We have seen as a community pulmonary emboli that have been very dangerous and require systemic anticoagulation, or even procedures that go and get the clot out of the lungs, which are very, very risky. And then finally, given the amount of tumor destruction that occurs in the liver, at times this can introduce a high volume of cellular debris into the blood system. And when the kidneys try to filter that debris, the kidneys can be harmed. So there have even been patients who've temporarily been placed on dialysis because the cellular debris has injured their kidneys to that degree.
Thank you so much for that overview. I'm going to direct the next question to Dr. Trankow, and this will actually address some of the questions that popped up in the chat around what size tumor can realistically be treated in a single session, and do you ever perform partial destruction for a larger tumor, and why or why not?
Sure. So the technology has some limitations, physically speaking. So for one thing, as Dr. Gingrich said, you have to be able to see it on ultrasound to treat it. And I think that's a key consideration. Right now, when people think about retroperitoneum or other disease sites, for the most part, we don't really use ultrasound to kind of, image those areas because it can be difficult to see it. So if you can't see the tumor very well, it's going to be hard for you to treat it, okay? But taking it back to your question about size limitations in the liver, at least, so we will treat tumors up to 3 centimeters. Anything beyond that, you're going to have to do overlapping treatments, which has a high risk of incomplete treatment. So really, we limit this to treating tumors that are less than 3 centimeters. As to your second question about intentionally treating only part of a tumor, we don't do that. I will say that from a oncologic standpoint, it doesn't make sense to me to do that, number one. Number two, there has been a case report, and again, it's a case report of disease hyperprogression, meaning after treatment, the cancer spread very rapidly. Again, it's a case report. I'm not saying that that's the thing that happens, but that particular case was because the tumor was incompletely treated. You could imagine a situation where when you treat a tumor incompletely from an oncologic standpoint, you can bring about immune cells, but also kind of pro-growth and pro-inflammatory kind of conditions that may allow the cancer to basically progress. So I would caution strongly against incomplete treatment of a tumor from my personal kind of vantage point. And I'd love to hear if the other panelists feel the same way.
I would just echo that. I feel like incomplete treatment with histotripsy is oncologically equivalent to an R2 resection, which is when we're leaving gross tumor behind. Multiple studies across multiple tumor types has showed no benefit to R2 resections. And that's just how, to Dr. Trankow's point, how tumors behave.
Thank you. I'm going to direct the next question to Dr. George. There's been some chatter in the question answer about GIST, and so I'd love to get you in as a medical oncologist and an expert on GISTs. So from a medical oncology standpoint, first I'd like to just understand how you think about local ablative therapies, because as we learned from Dr. Wang's presentation, there are many different kinds of ablations that we can do. So when thinking about patients with inoperable tumors, either in the retroperitoneum or abdomen, how do you think about ablation? And you can speak generally or specifically about things like GIST.
No, thanks, Dr. Lilley, and thanks for having me as part of the panel. I'll start by just thinking about GIST. So, GIST is a disease that we have learned so much about in the last 25 years, and we know that the backbone of disease control in GIST is effective systemic therapy, and that's typically with a kinase inhibitor or some type of drug that blocks KIT, which is the driver in this disease. But we also know that resistance develops to the various agents that we have, and that sometimes that resistance can develop in a heterogeneous way, like some of the disease can stay under control and some of the disease may start to behave differently. So if we have a clinical situation where there's a site that despite the drug therapy that we have that somebody's taking, there's one or two sites, a small number of sites that are choosing to behave differently or have developed a different behavior pattern, particularly if there's just one. It's in that situation that I feel it's really important for the team to have a multidisciplinary discussion about that case. And that means medical oncology, surgical, and for GIST, for me, that usually means medical oncology and surgical oncology. And I rely on my surgical oncology experts and colleagues, 3 of whom are on the call today, to help me sort out what is the most appropriate local therapy for this individual's clinical scenario. And we would review what are the surgical options, what are the non-surgical local therapy options, like ablation, for example, which we happen to do a lot of at our institution. Does histotripsy make sense? That's a question that I would put back to the multidisciplinary team. And then very rarely people think about doing radiation, but not so much in GIST as in other tumors. So to me, it's really about sort of the core care of the core multidisciplinary care in a setting where we might have a solitary site of progression, for example, that we might consider it. The other time that we sometimes think about local therapy is if everything's under great control and we want to consolidate that. But again, that's a discussion amongst the multidisciplinary team and really relying on surgical oncology colleagues to have that conversation around the range of options depending on the location of the lesion, the size of the lesion, and also what other drugs we might have available or clinical trials that we might have available that could be considered options.
Thank you so much. I want to direct a question to Dr. Raut next. So you see many patients with sarcoma, and I'm going to give you a two-part question. First, under what circumstances would you consider recommending histotripsy for patients with sarcoma? And second, what do you see as some of the main limitations right now when you think specifically about patients with sarcoma?
Thank you, Dr. Lilley, and thank you for inviting me for this panel. And I've been reading the questions in the chat and in the Q&A, and so I'll sort of try to address some of those questions. I wanted to start my answer actually by riffing off of something that Dr. Gingrich said, which is that it's important to look at evaluate each individual in our multidisciplinary clinic, and so when someone reaches out to Dr. Wang for consideration for histotripsy, we want to bring them into our clinic to see, specifically if they have sarcoma, for instance, to make sure that we're considering the full panel of options. We don't want someone to come, if someone came to me and said, I want you to take out my tumor surgically, I'm going to still recommend that they see our medical and radiation oncologist, because while we might offer surgery, we might also recommend giving radiation or trying to shrink the tumor with neoadjuvant therapy. For instance, if it's a large GIST, we might try neoadjuvant imatinib. So we want each patient that comes to us for a specific question to get the full expertise of our whole team, looking at their scenario and figuring out what's the best treatment that we would recommend. So it might not be coming in, and it might not be the same treatment that they were coming to us to seek, but we want to make sure that we give them the best options. So when someone comes in to our clinic now, if they're looking for histotripsy, Dr. Wang has actually had several patients where we thought they've actually never had the right operation that we would typically recommend, and has instead actually gone to surgery and not had histotripsy, but that was because we felt that their tumor would be best treated by an operation. So the patients that we do consider for histotripsy in our clinic right now, as Dr. George said, is a part of our multidisciplinary discussion. And right now, we are only looking at patients who have liver metastases as the ones that we will consider for histotripsy, because the FDA approval is only for liver-based metastases, not for bone-based metastases, not for lung-based metastases. But we evaluate that liver metastasis in the same way that we would evaluate someone before we had histotripsy. Should we take the tumor out? Should we give them RFA? Should we do SBRT as a radiation treatment to that liver lesion? And Dr. Wang, I had a patient who I was operating on, who I asked the patient to see Dr. Wang in the histotripsy clinic. So we've set up a separate clinic. I've actually joined Dr. Wang in those clinic sessions and in the operating room to see kind of what are some of the nuances around histotripsy treatment, so that I can be better about referring the right patients for histotripsy. But what we actually discovered as we kind of went through the process of evaluating this patient, histotripsy was not a great option. RFA was not a great option. In fact, we just needed to surgically remove the liver metastasis. So I think that's why it's important to really be properly evaluated in a multidisciplinary clinic. We don't really recommend, and because of the lack of data and for disease outside the liver, it is not something that we are currently doing or would recommend at this point. I know there's been a lot of interest internationally about this based on a couple of experiences, but it is not something that we're doing routinely.
Thank you so much. I'll ask Dr. Wang to follow up on that a little bit. And so there have been a number of questions in the chat about the use of histotripsy, which would be off-label, not FDA approved, for retroperitoneal sarcoma. I wonder if you could tell us a little bit about your thoughts about off-label use and how you approach patients who come to clinic looking for that.
Yeah, so I totally agree with all the panelists. We don't do, for the sake we have a device, and then we can do something, and then we do something. We have to see weigh the risk and benefit, whether we'll, it makes sense to offer patient options. In terms of off-label use, in our institution, so far we did 3 off-label use. But those are under the circumstance that patient has no any other options. We see the patient at the multidisciplinary clinic, and we make it clear that we don't even know what the histotripsy is going to do with the tumor. Okay. There's no benefit we can see. That's the nature of off-label use. We just don't know the behavior. And I think that the people who underwent histotripsy off-label use at our institution are heroes. They are contributed to the science. So why we do that? It's because we got to know what's going on, what the technology is going to do with the patient. As an academic institution, we are, number one, we want safeguard the technology, but we want to protect the patient also. Whether we do it or not, somewhere out there, because the technology available, are doing it. As far as I know, I don't have a comprehensive view, but I heard from the case review and other colleagues, there are multiple cases patient get treated for retroperitoneal sarcoma, lymph nodes, extremity, at least so far, don't quote me wrong, and then there's at least over in 2 double digits cases who do done off-label use. I think it's my responsibility to study it carefully. And then when we learn from that, and then we transition to clinical trial to study it under control environment. In fact, me, Dr. Angeles, and Dr. Xu from Michigan, and Dr. Omar from Roswell Park, and we are actively talking with the company. Now they agree to work with us to, now we learn from our off-label use, we need to transition to the phase 1 trial instead of continue to do the off-label use. From the experience I learned from the off-label use, we can see, at least from imaging point of view, it is able to destroy the tumor the treatment area we prescribed. And so far, we didn't observe any significant complications. Doesn't mean it's not there, just probably by luck, we only have a limited number. But we will achieve what we want to achieve so far. To be full transparent, we have 1 more patient we're going to treat off-label, but that's because we made a decision after we agreed to do that. That's a long time ago. Patient has other issue that postponed to now. But as a group, as a whole institution, we make a decision. We have enough information to move on to a phase 1 trial. That's why I want to give the message to the audience that we no longer do off-label use, but we do really try very hard to get this on trial so that we can learn more and then hopefully someday benefit our patients.
I'd like to ask Dr. Angeles, and I'm sorry for mispronouncing your name earlier. Dr. Angeles, if you've been there sort of since the beginning, working very closely with the inventor and engineer who developed this technology, as well as with some of the newer, more nuanced future technology, I wonder if you could tell us a bit about the process of bringing histotripsy to patients and where we are in that process, because the process of innovation and new technology is is a necessarily long road. So would you be able to talk a bit about that?
Yeah, sure. Thank you for that question. And thank you, Dr. Lilley and the LifeVac group for bringing me today and have this discussion amongst friends and colleagues that we all, take care of sarcoma patients, and we think about this very dearly about doing the best thing for our patients. So I think we have to be very mindful when we bring new technology to patient care without really doing the research behind the scenes of how the technology affects specific tumor types. So you saw the data on liver tumors, right? And we still don't have long-term outcomes, right? This is the theme you're hearing from all of us. And when you think about sarcoma, right, all the patients, you're putting questions in the chat about your specific type of sarcoma. There's over 100 different types of sarcoma. They all behave differently. Like how we approach them is differently. We have to think about that also with histotripsy. And, each tumor type also has different characteristics of what they're made from, and a technology that's ablative is going to be different depending on that type. So at Michigan, with my collaborator, Dr. Zenzu, who was a co-inventor of histotripsy, she has a really large bioengineering lab with a great team that we collaborate with. And I have my PhD students working with her. We're all working together to try to really understand how we can bring this to sarcoma. So we're fortunate that we have a lot of sarcoma patients that really love taking part in research at the University of Michigan. And so what we've been doing over the past year and a half now is one of our research studies. After I resect a sarcoma, not just me, my colleagues, when we take out a sarcoma, we actually take a piece of it, and you saw a little picture during Dr. Wang's presentation, and we do histotripsy on the ex vivo, so right, fresh tumor within hours, and do histotripsy to see what happens to the different tumors. They all don't have the same response, right? Which we expect, right? Some tumors are hard, some are soft. Histotripsy works really well for softer, well-differentiated liposarcoma, right? And then with more fibrous tumors like myxofibrosarcoma, doesn't work as well. So what we're learning is one dose doesn't fit all, okay? So there's different dosages. The current histotripsy machine gives one dose. You can change the size of the target, how many times you target, but you cannot change the actual pulses, okay, per volume that we have in our research machine, right? So we've given this feedback to the company, and this is coming, okay? So then there's the thing, okay, well, does it ablate it? Does it disrupt it? Does it kill the tumor? But what happens in the body? And so that's the next preclinical thing. So what we've been doing in my lab has recently developed a liposarcoma mouse model that has intact immune system, right? Intact like systems of body. And we give different dosages of histotripsy to these dedifferentiated liposarcomas to see how they affect not just the tumor, but the growth. You heard Dr. Cow say sometimes if you treat a tumor, it can grow faster, right? So we want to understand what is the right dose and is there a range, and how we can understand that. If we ablate the tumor, does it give the mouse kidney failure, right? All these things that we can try to understand in this model so that when we bring it to a clinical trial to the patients, it's based on understanding, right, what we're doing. And that's how we make a clinical trial for patients safer. So we're in the early stages, but when I say early stages, we're getting data fast to have an FDA approved machine that then they can change software to change dosages while we're getting the preclinical study, while we start working on the safest clinical trial protocol. I'm very, it's promising. I think we're going to get there. Our bioengineers are hard at work optimizing, right, what is needed to get the safest histotripsy response for sarcoma. And so I'm really optimistic. I think that it is going to be a great addition to our toolbox, but it's not there yet, okay? It's not standard of care. We don't know what it's going to do. You've heard some things today about how it can affect the system of the body. We need some more follow-up data collected in a systematic way, right? So even registries, all of our histotripsy users, right, that are doing histotripsy, we need to be collecting the data so we can understand what's happening in the patients, the ones that are getting treated, FDA approved in the liver. And then we have our preclinical data, and then we'll do a trial in sarcoma. So that's kind of how I see where we're going to go with this.
Thank you so much. I'll ask Dr. George the next question. So Piggybacking a little bit off what Dr. Angeles has said, as a sarcoma specialist, you see patients with many different, 100 different kinds of diseases. When you think about the goals of local therapy for all of these different disease processes, how do you sometimes say, well, sure, I think a local therapy would work well for this patient, but not for this one? So could you tell us a little bit about the thought process
Sure.
and why you would recommend local therapy for patients?
Sure. So, I think just as has been brought up, there are so many different subtypes of sarcoma, and sarcomas can behave in widely different ways. Some are very slow growing, others are more quickly growing. Some stay in one place, others have a higher risk to spread in other places. So when I think about the consideration of local therapy, and I want to be clear, I'm talking about tumor that has recurred, local therapy for tumor that has recurred, not local therapy for primary disease. That's very different. But when I think about when, we might consider local therapy for recurrent disease, I think about things like, how long was it since the tumor was last active? We call that the disease-free interval. Did we just treat the primary disease and now it's only a couple of months and the disease is growing quickly? Or has it been a few years and now there's just one spot? So that disease-free interval, I think, is important to consider. I think about the distribution of disease. Is it one spot? In that case, I might be more in favor of considering local therapy, but is it multiple spots in multiple parts of the body, which really suggests that we need a systemic approach as opposed to a singular local therapy approach. And then the third part that I think about is, what type of sarcoma is it? And what other tools do I have on the systemic therapy front? Meaning, do I have chemotherapy that I think will be effective? Do I have clinical trials that I think will be effective? And all of those things together help me to consider local therapy with the highest likelihood of looping you guys in for local therapy in cases where there's a long disease-free interval, a single site of recurrence, and a tumor type for which we don't have great systemic therapies. And those are often the ones that we bring to our multidisciplinary discussions for consideration of local therapy.
Thank you so much. I'll direct the next question to Dr. Raut. Are there any concerns that are specific to sarcoma tumors, including GIST or liposarcoma and others, such as tumor rupture or dissemination, that you think about when you think about histotripsy?
Yes, and I see that there's been some questions about, say, gastric GIST and some leiomyosarcomas and liposarcomas. And I think you saw in the video that Dr. Wang showed that the tumor liquefies, right? So if you liquefy a tumor inside the liver, it's sort of confined into the liver. If you liquefy a tumor in the wall of the stomach, and you heard Dr. Gingrich talking about, say, a hole in something, or Dr. Angeles talking about the different intensities that we need to use for the histotripsy ultrasound wave. If you ultrasound, or if you destroy a tumor in the wall of a hollow organ like the stomach or the intestine, and it melts, then you have a hole in that organ left. Whereas if we took that tumor out surgically, we're going to staple or suture that hole closed. But if you histotripsy it, you have a perforation, and that's a surgical emergency. Likewise, if you have, say, a retroperitoneal sarcoma, and it's histotripsy, and it melts, but it's not 100% completely killed, because we still don't know the right intensity for a liposarcoma or a leiomyosarcoma or a GIST, and it sort of partly ruptures because it's partly liquefied, then it's spilling tumor. And we have great data to show that if you rupture a retroperitoneal sarcoma, it is a 100% chance to recur. If you rupture a GIST, the prognosis is the same. Everyone on this chat would know it's 100%. It's the same prognosis as someone with metastatic disease from presentation. So we have to be really careful about something that's not confined within something like the liver, where it won't necessarily disseminate in the same way that it would if it were in a solid organ or in the retroperitoneum or in the peritoneum. So before we can really this is not a technique that can replace surgery for localized primary tumors that can be safely removed. It is not, we're nowhere near there. And just as imatinib did not get rid of the need for surgery for GIST, it changed some of the indications for advanced GIST. But it just surgery remained a key tool in the armamentarium. Histotripsy could potentially be another tool in the armamentarium, but only if it can be done safely, like in the liver, at least until we have better technology to be able to treat these more safely outside of the liver. And we're just not there yet, but I think we're all looking forward to Dr. Angelia's research to help us get there.
Thank you so much. And I'm going to award a gold star to Dr. Tran for all of his answers in the Q&A. So thanks for that. The next question will be again for Dr. Angelis. There have been a number of questions in the chat asking how patients can stay informed about the progress of your research and the results, and also how whether there's any sort of timeline as to when a trial will be up and running and available and ready to enroll patients.
Yeah, great. Great question. So, our work, we, presented at, research meetings. We're in the process of getting our early data with all those different tumor types that we took out of patients and did that. That's going to be published hopefully soon. We've submitted that. Also in forums like this. That's why these webinars are great, right? With our groups to kind of disseminate this work. I think that we as a group, Dr. Wang, we've been talking about is getting a clinical trial up and running takes a long time. So it's not something that we'll do step by step. Like we wait for our data in the lab and then we start thinking. We will do these in parallel. We start to think about how we can do a clinical trial safely while we're doing, getting data in the lab and bioengineer. So we're going to work on this together. I think that we have to, my message to patients, and I tell my patients all the time, it's not ready right now. We still have all the other tools that we used for you, and histotripsy hopefully will be something that we'll have in the near future. How soon, I don't know. I would imagine the clinical trial will be ready within a year, but we'll see, right? I think the most important thing is that we do it safe. And I want to echo to not just all of us here, but for all of our providers that do histotripsy throughout the country, we can get clinical trials for sarcoma and other diseases safer if we are collecting the data on safety from all our patients that are being treated, right? And so that's called, just for patient, that's a registry trial. If you see your doctor and they say, hey, will you take part in a registry trial? That's what we're just following your data, right? And we're collecting outcomes, and we can learn a lot from that if it's collected, right? And we can learn from that. So when, in terms of being cautious, what we need, I think that data is going to be important. And, all the things we're doing in our lab. There's a lot of research being done on histotripsy also at other institutions, like in the preclinical that we don't hear about because it's all new, right? New technology, new things. So in the next year, I think we're going to be getting a lot of data to really understand how to use this.
Thank you so much. I'd like to ask a question of all of our, did someone say something?
Yeah, I just want to echo Dr. Angela's comments. I think it's great. And the lab work, preclinical work in her lab has been very informative and very important, critical for the future success. And Dr. Angela's really well articulate, we will work parallel. We don't wait, and there's no such a thing as perfect. Even like, for example, radiation therapy, we still is evolving. So we will work together for both parallel for trial and also while optimize preclinical work and optimize the machine delivery. As I speak, represent myself, not represent group, but I hope I saw the chat. We talk a lot of things sounds like a negative to the histotripsy. That's not true. Okay, if you have that impression, I'm telling you, we're not here to say histotripsy is bad, it should not be used. We are saying we are responsible for our patients. And also we want to protect the new technology. Okay, the technology is promising, we like it, we want to adopt it, but we have to do it a scientific, rigorous way while protect the patient. So that's a message. So don't finish this webinar. I don't want you to leave with the impression all those people are so negative, I will not talk with them anymore. No, that's not the impression we wanted. I don't want to deliver. Other panelists can, comments about that too.
Yeah, I agree. I think that everyone is on this panel because they believe or hope that histotripsy can be really beneficial to patients, especially if it is studied and brought to patients in a way that's safe. Dr. Raut, I see your hand up.
Yes, and just to echo what Dr. Wang said, some of the people tuning in probably remember. I'm sorry, I'm getting like sunlight, so if I'm blinded. But we'll remember that maybe 20 years ago, heated intraperitoneal chemotherapy was being considered for GIST, because that was or maybe 25 years ago. It was before imatinib came along. Heated intraperitoneal chemotherapy, or HIPEC, was considered. It turned out not to be particularly effective at all in GIST, but imatinib came along and turned out to be quite effective. So just like HIPEC, histotripsy is a technology. It's a technology that we're still trying to understand what are all the indications, just like we are still for HIPEC. And it may be that for some sarcomas or sarcomas that are outside the liver, it may not be an indication, but it might be a very good indication for metastases to the liver. We're still in that exploratory discovery phase about really what is the role of histotripsy in our treatment, in the treatments that we offer. And we don't want to offer something that is going to be either unsafe or ineffective when there might be other good treatments, including standard therapies, TKI therapies, chemotherapy, surgery, or radiation, which have a longer track record. They may not necessarily be the right treatment for everybody, but the same can be said for histotripsy as well.
Thank you so much. I want to ask a question of all of the panelists next. What data would you need in order to feel more confident or more cautious about histotripsy for patients with sarcoma? And I'll start with Dr. Wang.
Yeah, so it is a very important question. So I would say I really want to see the level of the pathology level of data. That make me feel safe. Okay, whether, when, how to do it. I want to see if we treat. Right now, on the chat, people talk about, I mentioned 50% of mortality patients on that trial. I think that that doesn't reflect the histotripsy treatment effect. It reflects the patient might have end-stage disease. My point of mentioning 50% is that when you see you have disease control at 1 year, but if you have a patient die at 6 months, when you see 1 year, the data is wrong. That's the point I want to make. My point is that because we don't have long-term oncologic data to see, like, for example, drug trial, when they do drug A versus drug B, which is better, they give patient drug, they follow 5 years, and then see whether drug A will improve whatever, 10%, 20% of 5-year survival. We don't have the luxury to study for histotripsy in this parallel setting. Instead, I personally strongly believe what's the next surrogate is that when we treat the tumor, we don't rely on the CT scan or MRI look at black hole, because we don't know whether there's still live cell behind there or not. So my goal is that if I treat the tumor, I cut it out and look under microscope, the tumor is dead, then make me feel comfortable to use that technology for that specific tumor type. For example, leiomyosarcoma or liposarcoma or whatever. And then we treat the tumor at some location, we can treat the whole tumor. I feel safer to do that. I won't feel safer to do that unless I see the pathology data.
Thank you. I wonder if other people have other things that they're waiting for or hoping to see in the data.
Yeah, so I just wanted to kind of echo what Dr. Anjali said earlier is the bottom line is I'm very optimistic for this particular technology. I think there's an unmet need that histotripsy can potentially fulfill. But I do think, and this is I think we're all in agreement on this panel, is that histotripsy just deserves the same amount of systematic rigor in its testing as any other technology that we have. Surgical procedures, HIPEC, microwave ablations, all of these things that have been mentioned. Just because it's promising doesn't mean it gets to jump the line. So phase 1 trials prove safety, phase 2 trials prove efficacy, and histotripsy needs to be put through those same paces before I can have an educated conversation with the patient as to the risks and benefits of offering them histotripsy for their specific tumor type and location. At this point, we're just lacking some of the data to supply me with information for that conversation. So sort of as we've gone over the Hope for Liver trial, we have some early data from that. I did see a question in the chat regarding the mortality rate for a year post histotripsy. And yes, that is a little bit conflated because histotripsy is being used quite often in the palliative setting for metastases and metastatic disease that has not responded to other therapies. So we are going to see a higher mortality rate that's not specifically due to the technology, but to the patient selection. And so just with what am I cautious about? What am I hopeful for? These are the things I'm thinking about.
You're muted.
Dr. George, I see your hand up.
Oh, yeah. No, I just wanted to actually build on what others have said and what Dr. Gingrich was just talking about. I mean, I think from the medical oncology perspective, what I hope to see is not just the disease control at the treated site, which is what the data that was presented earlier, but really this gets to this issue of patient selection, right? Like if you can control a spot in the liver, but the rest of the disease is active and doesn't seem to, is really what becomes the threat to the patient, then we have to think about that very holistically. I think that, as others have said, I think that there are likely different settings in which to answer different questions around the safety and the efficacy of histotripsy. So some in which really focusing just on that spot that's treated, recognizing people may have other disease, as Dr. Gingrich said, that it could be that options otherwise are extremely limited, but this is an opportunity to learn about that one, technology in that one spot. I think that's really important as long as everybody understands that that's what the question is being asked. But I think in the longer term, it's really going to need to then translate into patient selection. Like if we figure out it works really well when you treat a spot, who are the patients and with what diseases do they have that those spots should be treated as opposed to using some other modality of treatment, either local or systemic.
Thank you so much. I think that some of the other questions I had planned have kind of come up in conversation. So we're going to go a little off the cuff and what is in the chat. A question that many patients ask about is something that people have heard of called the abscopal effect. And I was wondering if maybe Dr. Tran can talk a little bit about what that is and how often that is observed.
Sure. The answer to your second question is simple, which is we don't know. So abscopal effect has been described for more than 50 years. The idea is that you treat one area, one particular tumor, and then you have a response elsewhere in non-targeted areas. And the idea is that the treatment that you did perform on that one tumor somehow got your immune system to boost up and then start attacking the cancer everywhere else that it may be, right? So that's abscopal effect. That's been described for radiation. That's been described for IRE. That's been described for ablation. And unfortunately, it has not yet borne out. In the case of histotripsy, The reason why people kind of lean on that is because you're not destroying the tumor with heat, and so that you're not denaturing the antigen. But again, whether that is a real kind of phenomenon that we're going to see, we have no data currently to support that with any degree of strong data. So I understand, right? When you've got disease that's everywhere and you're like, man, if you treat one tumor of mine and that's going to get my immune system to fight the rest, I understand the appeal of that. The unfortunate truth is that we just don't have the data to really show and support that claim. And there's a lot of work that needs to be done to make sure that that's going to, be something we can tap into. And it's an area of interest for all of us. I'm sure Dr. Angelis and Dr. Wang raising their hands are going to speak to that. We have an interest at Anderson as well to combine the histotripsy with some other immune potentiating treatment to try to see if that can be a real kind of benefit. But right now, we just don't have that data.
Dr. Angelis, would you like to comment?
Yes, thank you. So just going on to that, this is where preclinical models, right? We can test some of these things about how the immune response is affected with different dosages. So you heard me before talk about different dosages. So if you get a certain dose that kills the entire tumor, but then also you kill or destroy maybe antigens or things that are going to make the immune response, then you're going to have a less chance of inducing the immune response. Okay. But then maybe you don't kill as many tumor cells, but you have a better immune response. So these are all things we're testing, and not just in sarcoma. So we have a lot of laboratories at the University of Michigan that are testing this idea of abscopal effect and immune response in a lot of different tumor types, colorectal cancers, breast cancers, melanoma. So we're doing that work. Again, I know patients want the results tomorrow. We would love that too, but it takes a little bit more time. But we're really, again, trying to understand how to get the best tumor kill, but the best immune response and best overall systemic protection, like you heard from Dr. George. We want to understand how this is affecting the entire body's response to histotripsy.
Yeah, and I'll ask Dr. George or maybe Dr. Raut to comment on specifically in sarcoma. Do we see the abscopal response, which has been, as Dr. Trenkow said, described for 50 years? Do we see it very often in sarcoma?
I can't say that I have. I don't think so. I wish we did. I wish we had the right combination of local therapy and drugs in order to see that, but it's not something that I think we've seen in the sarcoma community. I don't know, Chan, if you feel differently.
Right. The answer is no. I think that it's something that we consider. I remember when in the early days of immunotherapy, we thought about combining immunotherapy plus radiation to try to get an abscopal effect. Didn't really see that. It's not to say that it can't happen, but I think that to kind of bank on it as something that has been proposed for histotripsy is not necessarily the reason that we're pursuing it. We want to try to investigate it as a potential treatment option, but not purely because it's going to have an abscopal effect that hasn't really been borne out.
Thank you. And Dr. Wang, your hand's up.
Yeah. So I want to play the devil here. So I want to echo and add on Dr. Trankow's comments. Yes, we don't know the mechanism of the the abscopal effect. However, my personal opinion, now I'm wearing my statistical hat on. I, like Dr. George and Dr. Raut point out, they didn't see one. What does that mean? That there's a p-value of 0.05 means when you see less than 5% chance, that's very likely it happened by chance. This is impossible to happen. Okay, that's why we use 0.05. I want to apply it here. We rarely see the, number one, the abscopal effect happen to, like Dr. Trankow said, to any other local treatment also. It's not unique to histotripsy, number one. Number two, the frequency that we observe abscopal effect is so low, it is not if you look for that, that's the wrong way to look at it. It's impossible to happen. It happened just by chance, okay? Therefore, I want to tell the audience or the user, the patient, even if, again, I'm playing the devil. Even if you don't have any other options, you say, hey, I don't have anything to lose. I just try to see whether there's an absolute cobalt effect. And you need to pay whatever, 50,000 to 60,000 to get the treatment. I still discarded that because it's impossible to happen. Okay. So I can be very responsible to say, don't just look for only for abscopal effect. That's a wrong way to look at the question.
Thank you. Alicia, I see your hand up.
Yeah, thanks. I think this is just a really hot topic for those of us that see patients in consultation for histotripsy. And I know there are some high volume histotripsy centers that really push the benefits of the abscopal effect. So what I would just like to say to the patients on this webinar is if you are meeting with a histotripsy provider and you have a solitary liver mass 4 centimeters or less, you've been discussed in a multidisciplinary setting, and histotripsy has been chosen as the preferred modality for you, I think that's a very different informed consent conversation about the benefit that you can expect from histotripsy than if you are meeting with a provider whose goal for you and your multiple liver tumors or extrahepatic disease to experience an abscopal effect. The chances of that at this point are theoretical and the data is speculative. So if you're being told you're getting histotripsy to induce an abscopal effect, that is not a thorough informed consent conversation at all. And even if you do, again, I don't want to sound like the pessimist on the call because I really am optimistic about this technology. Even if you do experience an abscopal effect, we have zero data on how durable that response is and how long that's going to last. Meaning at some point, if there are microscopic cancer cells that remain, there is a chance that those can once again outpace your immune system and the disease could come back. So it's very important to have the conversation with your provider. Is this histotripsy for curative intent? Is it for palliative intent? Or are we chasing something that may happen within the statistics of small numbers? Those are 3 very different conversations.
Thank you. I know we're coming up on time, so I want to throw one final question out to all of the panelists. And actually, I'll throw out 2 questions, and you could choose which one to answer. Option A is, do you feel that histotripsy is ready for widespread use in sarcoma, or should this be limited to research settings at this stage? And option B is, what would you tell patients and family members who are listening here today, if they're interested in histotripsy, what would you tell them they should talk to their team about? What is the question that they should be asking? So I'll start with Dr. George.
Hi, Liz. Thanks. I think I'm going to go with B and actually reiterate what Alicia said. I think that if you're thinking about doing histotripsy or exploring it, it's really important to put it in the context of what to reasonably expect from it. I think that it's not, I'm going to jump on, that's what I think. I know we're short at time. So I just think it's really important to understand what's reasonable to expect and what the risks could be.
Thank you so much. Dr. Tran.
Yeah, I think Dr. George and Dr. Gingrich answered the second question very well already. I think to the first question, I would say it's not ready. As Dr. Angeles said, there's so many parameters, so many features, so many factors that play into whether this technology can be effective. But if I may, I just want to summarize to the audience today. In my mind, the current data only supports using histotripsy as a local therapy option, period, as a local therapy option for tumors that are in the liver. Anything else, any other application, any other location should be studied on a protocol where people are closely monitoring the outcomes and the safety and the effectiveness of the therapy. We want it to work, but we've got to do it responsibly.
Thank you. Dr. Raut.
Now, I'll just echo what you've already heard. It's only for liver metastases or primary liver cancers. And as Dr. Gingrich pointed out, what is the intent of the treatment? Just like every other treatment that we provide, is it for palliation because there's a symptomatic liver metastasis, or is it as part of a planned aggressive multidisciplinary approach of often combining surgery and radiation and histotripsy or other local ablative options? All of that should be considered and really articulated so that each person who's getting that treatment understands what the goal for that treatment is. But it is for anything outside the liver, it is not standard of care. And as we would love it for it to be at some point, but only after rigorous investigation to make sure that it's safe and it's actually achieving what we intend it to achieve, that it's an option that might be better than surgery or drug, and not inferior or putting people at risk for worse outcomes.
Thank you. And I'll open it more broadly to final thoughts. Dr. Angeles.
Yeah, I think we're all saying the same thing. I think this should be used in a, histotripsy for sarcoma patients in a research setting. And if patients talk to their provider, say, hey, if a clinical trial opens, let me know. Okay, so not how can I get a ton, but instead let me know when there is a clinical trial or more data. And those conversations can be, with your provider.
Dr. Wang.
Yeah, so I think we all say the same thing, but I just want to give additional further comments about to the audience. We as a group, you can see we have a consensus. We think it's not ready. We think we need to do. If we're going to use it for anything outside the liver, we have to do it under protocol, to do a rigorous study, well-designed, well-informed the trial before we use it. However, that being said, we are not here, regulatory body. We're not here to say, hey, you cannot do this. We're not advocating. We think it's consensus. If you look for somewhere else, again, I'm not advocating. I just gave my personal advice, looking you as a friend or people I know. If you really want to look somewhere else to get this done, what you should talk with your provider. You should clearly ask them to articulate the goal, specific goal, 1, 2, 3, what do you want, what you want to achieve, what they can achieve, to write it out, to help you to make a decision. And then see what's a risk, a true risk you're going to encounter, whether it's worth it, why you think it's worth it. You need to ask the hard questions, that because this is not ready. That's my personal opinion. I'm not an advocate for you or advocate for this action. But if you do, I understand that people, when you have no options, you want to get some answer. This is my advice.
Okay. It looks like we are at time. I want to thank all of the incredible panelists for their honesty and their commitment to their patients. And especially want to thank every patient and caregiver who has submitted questions, who continues to push this field forward, who continues to advocate alongside organizations like the LifeRaft Group for the need for really rigorous study to help patients with sarcoma. Thank you all so much for joining us today.